Hello dear colleagues, and we continue our theoretical course regarding guided surgery, implant surgery as well. Today we are going to talk about closed sinus lifting, open sinus lifting and osteoplastic surgeries at all. My name is Nikita, I'm a dental surgeon and I have made more than 1,000 clinical cases using surgical guides. And please take a closer look at the comments below the video, at the description of the video, because you may find some interesting information there for you. Let's go. Hello again, dear colleagues, and we continue our theoretical course dedicated to implant surgery. This is the intro to the implant surgery. One just disclaimer that it will not replace university education or any other education regarding this topic. I will just quickly, briefly introduce you to the main aspects of the work, theoretical one. So now we are going to talk about implant accesses and how they should be performed. Actually, as far as you know, probably from prosthetic dentistry, the accesses are quite important because they actually affect the successful fitting of the guide of the of the prosthetics, because ideally, like in this picture, the axis of the implant have to be absolutely parallel, so the fitting, let's say it so, will be passive. What does it mean passive? That you do not need to apply any additional force, movement for the prosthetic for a prosthesis in order to fit it to the superstructure of the implants. So when you have such cases, and we have discussed it a bit earlier on previous video of when we were planning all-in-4, all-in-6 cases and so on, we are trying to actually make axis of the implant as much parallel as we can. Ideally, they must have 0 degrees between each other, but usually it's very hard to do. It's very hard to do, and sometimes we get like this. No, I'm kidding. Yeah, some small divergence of the axis can be actually performed, and it's possible, and most likely it will be. And since we are talking about the multi-unit abutments, they actually were designed to compensate the divergence of the axis, divergence of angles, and usually when we talk about multi-unit abutments, the literature says, I mean scientific one, says that the 20 degrees is the maximum divergence between multi-unit abutments. But since you get such a situation while implant planning, you realize that most probably you will have troubles with fitting of the this prosthesis on the multi-unit abutments. But if it fits, that doesn't mean that everything is okay, because if you're applying some force to fit this type of prosthesis onto divergence multi-unit abutments, some internal force, not actually some one, it's called internal force of the prosthesis of any type of actually solid material appears inside the prosthesis, and it's the probability of the breakage, the probability that it will just be broken, is much higher. Therefore, in order to avoid these internal forces and so on, please try to make axis as much parallel as you can. And now we are going to talk about osteoplastic surgeries. What does it mean, osteoplastic? That means that during the surgery, we as oral surgeon, as dental surgeon, try to change the bone configuration. We can reduce the bone, sometimes it's needed, it's called bone reduction, or we can add some amount of bone, and sometimes it's needed as well. At your screen you can see the scheme of open sinus lifting, how it's be performed. Let me just briefly explain you. Firstly, the surgeon has to make a flap here. Secondly, surgeon makes some kind of a hole at the lateral actually side of the maxillary sinus. Yeah. And after that, we have to lift the Schneider membrane upper, because this layer inside the maxilla is also the soft tissue, and surgeons actually lift it in such a way that they create some space between this, it's called probably native bone to my mind, yeah, and therefore we get some extra space here to install the implant. So this space is being filled with some kind of different types of osteoplastic materials. It can be outer bone, xenobone, and so on, so on, so on, PRF, and etc. So this type of operation is provided when there is extreme lack of native bone, so there is almost no bone, but the dental implant needs to be installed here. Most commonly that happens on the 6th, 5th, 7th teeth and so on. So this is the example, just a very simplified explanation of how it works. Why do I talk about that in the regard of guided surgery? Because when you plan when you plan a surgical guide with open sinus, firstly you can make a surgical guide for this window. But anyway, I'm not talking about that. We are talking about the guided implant surgery. So if you plan it as for open sinus lifting, this operation is called open sinus lifting. We just do not care about native bone, because this because the implantation for open sinus will be after sinus lifting is being done. So therefore, while planning it, we just don't care about the borders of the sinus, because we assume that it will be already done by the time we will place the implants by surgical guide. Otherwise, there is another operation which is called closed sinus lifting. Closed sinus lifting is not so actually traumatic like open sinus lifting, because we do not need to make such a big flap, but we have to take into account while doing closed sinus lifting, and we are performing a guide modeling here. We have to take into account the border of the sinus, because our goal is to create surgical guide in such a way that drill has to be stopped nearby the border of the sinus, and never ever it has to be perforated, but we have to plan everything in such a way that we should stop the drill just nearby, especially usually it's for about 1 millimeter length there and so on. So how it's being done? We have initial situation, and we realize that most commonly, here's, let's just pretend that here is like 6 mm height of the native bone. We just we are drilling it with a guided drill and stop-over drill in front of the sinus, just 1 mm below. Then the surgeon takes such an instrument, osteotome, and just lifts with this instrument, just slightly lifts for about 1 to 2 millimeters. It's called, I saw the word roof. Maybe it's called in something like another way, but you just have to realize that it's just a small particle of the bone which is connected with the Schneider membrane, and by lifting this bottom, actually, by lifting this roof, sorry, by lifting this small piece of bone, we are lifting for about 1 to 2 millimeters the bone, and we insert successfully the implant here. So, dear colleagues, this is the end of this lesson. Many thanks for watching. Please put your like to this video, share this video with your colleagues, with your friends, and subscribe to this channel. Please also take a look at the comments below the video, at the description of the video, because you may find something interesting there for you. Nikita was with you. Good luck with your job. Take care and bye-bye.